session on the role of the private sector and pharmacies in the provision of family planning services. My name is Sarah Reese, and I am the moderator of this session. I am a senior demographic and health researcher at the DHS program. We have 4 great presentations for you today. So I'm going to just introduce our panelists in the order they will present. And then they're each going to give a 15-minute presentation. And then at the end, they can come up and sit here, and we'll have questions from the audience, and then they will respond. We do have 1 presentation in French today, and 3 in English. So if you need interpretation services, there was a QR code up here, and hopefully you were able to get that. If not, you can go to the back and they should be able to help you. So our first presenter is Teski Koba. Dr. Koba is a physician and public health specialist. He has worked as an attending physician in the private sector in Lumumbashi in the Democratic Republic of Congo. He consulted at the University of Tulane and the Kinshasa School of Public Health, where he participated in several large-scale studies in the field of reproductive health, as well as maternal, neonatal, and child health, and he is an expert in ODK programming. Second, we have Monjan Nahar. Monjan is a sociologist by education. She has a master's in development studies from Bath University, and she has more than 24 years experience in the development sector in the area of gender equality, reproductive rights, policy advocacy, and research. She has published on sexual harassment in the workplace, policy assessment on reproductive health, and she advocates to the Ministry of Health and Family Welfare for family planning funding and to accelerate the SRH rights and women's well-being. Glad to have you. We also have Rita Wadimba. So Rita is a public health and management specialist with 16 years of work experience in strategic leadership and guidance, design, implementation, monitoring, and management of development programs in health and capacity building. She has supported programs in sexual reproductive health and rights, HIV/AIDS, refugee areas, WASH, and in humanitarian settings. She has worked with government development partners and other stakeholders, nurturing relationships for successful delivery of development programs, and is currently the chief of party for the USAID Uganda family planning activity. Rita, we're glad to have you. And finally, we will have Emeka Okafor, who is a seasoned private health sector engagement expert with over 19 years of experience managing complex public health interventions in Nigeria. He holds a bachelor's degree in pharmacy and a master's degree in project development and implementation. Emeka currently manages the Integrity Project, funded by the Gates Foundation and MSD for Mothers, and is implemented by a consortium of partners led by the Society for Family Health. This project seeks to expand access to quality family planning services through community pharmacists and the patent and proprietary medicines vendors, or PPMVs. So this project seeks to redefine the way family planning services are provided by pharmacies and drugstores and provide evidence for policy change for sustainable development of community-level health services for those in need. So Emeka, welcome. And without further ado, we will have our first presentation. So Dr. Koba. Yeah.
Bonjour tout le monde et merci beaucoup d'être venu.
Good morning, everyone. Thanks for coming here. I have the honor of presenting the results of the study on feasibility and acceptability of use of informal pharmacies in Kinshasa, in the Congo Democratic Republic. So we are assessing the medical services according to their efficiency, Of course, we are also giving medical training. And these activities also are suffering from supply problems. It's a cohort study following women for 6 months. That study proved that the difficulties in supply were the first cause for the lack of continuation. So between 2003 and 2014, more than half of the women went to get contraception in those pharmacies, but the potential was not used enough in family planning. In Kinshasa, we have 5,000 pharmacies. Only 2% have obtained the approval from the health ministry. Most of those pharmacies are in the city center and are mainly providing services to the foreigners. They do not really have a status as a pharmacy. They do social marketing and they are rejected by health programs. The service is bad, uh, no reactivity, no quality control. A first study was carried out in 2017 in order to integrate better those pharmacies. These pharmacies targeted urgent contraception. The goals of this study uh, to the goal was to study acceptability and feasibility of using those pharmacies. Were they reliable for clients of the MPA SC? So to reach the goals, we tried to see whether those pharmacies were able to provide counseling and to have enough supplies of doses to manage wastes. We wanted to know whether these pharmacies could be a supply site for women already using contraception. And we also wanted to see whether they could be used as a collection site for used doses. So it's a transversal study, and the design of the study is that we started first with drugstores, pharmacies, but some were excluded from the study. 4 zones were designed. All the whole mix of contraception methods was presented, and we studied those using DMPSC as a basis. So DMPA clients go to health facilities or what we call basic suppliers, community suppliers. So we tried to guarantee a supply after 3 months, and we tried to see whether this was working. And there were interviews, classical interviews we had with those service providers within the pharmacies, and we studied the mystery client effect. So we our study covered several areas in Kinshasa. So we had various experts intervening here. The interpreter is sorry, but the sound is absolutely awful. It's very difficult to hear the speaker. We're trying our best. So 254 visits were carried out during February 2022. So the scenario of the visit is the following. The client comes to the service provider to get supplies or to throw away the previous doses and wastes. In order to assess the feasibility, we, we, we used the following results. The number of doses, the management of wastes, and the capacity of the service providers. 3 months later, 3 pharmacies closed down. Almost all the service providers accepted to give the doses to the mystery client. The price per doses was 3,000 francs, which is 1,500 US dollars. For the interaction between the client and the service provider, 88.8% asked the client whether they knew how to do the injection. 85% asked whether they had used it before, and 62% were asking the date of the previous injection. Only 34% of service providers asked questions about secondary side effects after the first injection. 28% asked a proof of capability to do the injection, and 1 out of 10 provider expressed reluctance to give an additional doses. Concerning the advice, the counseling, 3 out of 4 gave additional information and advice. 55% asked about gave information and advice about how to throw away the doses, and how about the date of the next injection, and proposed an additional injection. Few gave advice about the side effects. Concerning the management of waste, 9 out of 10 accepted to receive the used doses from their client. 1 out of 10 asked the mystery client, to bring back the wastes next time. Only 1 provider asked the client to bring back the used doses to a health center with the capacity of managing biomedical wastes. About the attitude of the providers, 7 out of 10 considered it was acceptable. So what can we remember from this study? The result was to confirm the acceptability and feasibility of using informal pharmacies to support DMPA users. Those results can give information about strategies to be adopted in order to use those informal pharmacies to be a resupply center for DMPA, and they should be integrated into the health service. This would, of course, increase the number of channels where contraception can be acquired, and it'll provide fair access to women and also to groups that are more difficult to reach because they are close to the population and because they preserve privacy. So this is all I have to say. Thank you.
Thank you. Welcome to my presentation. I'm Monjun from Maristops, Bangladesh. Um, Today I'm going to share my case from Bangladesh, creating private sector family planning access points in Bangladesh. And my presentation is consisting of objective, methodology, context, and conclusion. So again, welcome. So background is that, next slide please. Yeah. Why this is important, why we are working on the issue to increase family planning service in Bangladesh. We work in a Khulna division, is the third largest economic zone in Bangladesh and a hub of fiber, fish and sugar companies. Around 15.7 million people in Khulna are employed by these informal sectors. About half of the employees are young women from poor social and economic backgrounds. Generally, the healthcare centers are open from 8 a.m. to 2:30 p.m. and the women workers have a limited ability to visit healthcare centers due to their working hours. And thereby, lack of information and services have made their lives more vulnerable and put them at risk of unintended pregnancies and unsafe abortion. If we see the overall context of Bangladesh, we found that high unmet need till is 12%, and highest unmet need among married teenage girls is 17%. And discontinuation rate is 30%, and child marriage rate is 59%. So this is the context. So that's why to increase the coverage, we took private sector as a point. Next. Yeah. Our advocacy objective was to explore advocacy opportunities within the private sector to reduce barriers to contraception and unmet need by offering provision of family planning service in the workplace. Our advocacy ask was to ensure family planning service and information for the female workers of the companies by the owners and the local family planning department. And the message we want to give the owner is that if their right is established, they get access to family planning, they will satisfy with their owner, and also their productivity will increase. So challenge was there because, external interruption is not allowed by the owners. Actually, they are working at adolescent girl, that is conflict with the labor right and everything. So a lot of conflicting issues were there. But our key message convinced them that if dropout rate is reduced, then they will make more work, more production. Next page, please. The methodology we have followed, that is landscaping. We did the total landscaping background assessment, everything, make worker profile, and then we develop a smart advocacy strategy. We identify the decision maker, the message, and everything, and risk benefit analysis to mitigate the challenges. And then we did the continued dialogue with government official and the owners of the informal sectors. And also we have lot of coordination meeting with the government and the fishing company authorities. Next page, please. As a result of our sincere advocacy efforts, we found that Initially, 10 fishing companies agreed to allocate appropriate space for the camp and allowed workers time to receive the service. And by 22, fishing companies have come under the model expanding unmet APRA service to the ultra-poor workers. And local family planning office is maintaining data system, making it easy to incorporate the service data into the national management information system. So it is the part, it has become a part of the government data system. So as the result of our pilot, we have found that 15,000 workers has reached under the program. The gender, definitely 58% is female and youth is 35%. Next, please. And we can see the graph here. And when government official, we took them in the visit in the companies, and then they asked why it is important. Then a girl said that, how could I work if I am not well and have more children? A worker said during visit of the government official. So they claim themselves. I have to establish my choice, my right, otherwise how can I work here? Next, please. So, well, our conclusion is that well-coordinated and collective initiative contributing to reducing unmet need for contraception, unintended pregnancy, and unsafe abortion too, promoted women workers' health and rights and increased productivity, which was a key evidence piece for buy-in from the factory owners. Involvement of the local advocates enhance accountability of the service providers and ensured continuity of service. The right of the client promoted, as many workers are not able to access service otherwise. Actually, it was our advocacy takes to motivate the owners. We really focus on their productivity. And the government official, we focus on their right issue. So in a way, and we involve multi-sectoral advocacy group from the local level. That really helped out. Next, please. And implications. We found that public-private partnership created an opportunity to increase access to AP service and counseling for the company's female employees, and around 15,000 women and girls now have access to service. The success of the program has encouraged the divisional office of the Department of Fisheries to issue an order for all the fishing companies of the region to adopt this model of AP service delivery in their factories. So it has replicated by the government. So now, near about 70,000 workers will have benefited from this advocacy initiative. Next, please. And thank you. Thank you.
Thank you. Rita?
Good afternoon, everybody. Welcome to our session. As introduced, I'm Rita, and I'll take you through some of the work we've done in Uganda, working with the private sector, in this case working with private drug shops, to increase access to family planning in the community. So this is a photo where we have one of our health workers that we work with in the drug shops, taking a woman through one of the contraceptive methods. So as a way of background, I thought I should start with some statistics. These are taken from the Uganda Demographic and Health Survey. The unmet need in Uganda, as per that study in that survey in 2016, was 28%. and we have a teenage pregnancy of 25%. So the next one is ongoing, and we're yet to see how that picture has changed. And the key drivers of these statistics that we are seeing here are mainly long distances to the health facilities, where on average somebody will move about 5 kilometers to the nearest health facility to access these services. There's also a high cost of transportation to these facilities, and then the long waiting times in these facilities kind of turn the women, the girls, the boys away because they are not sick. So what we decided to do was to leverage the private sector to expand access to family planning. And why private sector? So in these communities, you'll find that the public facility, which offers free services, is far away. And so you find that in this community, there may be a drug shop which can easily be accessed. So in Uganda, we have over 6,000 drug shops that have been registered, and there are lots more that are not even registered formally. So these serve about 80% of the population in the rural areas. So there's a great opportunity there for us to increase access to services through these facilities. Now, following a pilot on working with the drug shops, the Ministry of Health and the National Drug Authority issued guidelines on allowing the drug shops to provide short-term contraception. The focus here was on injectables. And we seized this opportunity to increase access to these commodities through this policy that had just been passed. So what did we do? We mapped drug shops in those areas where we felt that the public facility was far and this service would be very much needed. So we brought on board about 18 drug shops, and then we trained the drug shop owners or operators. Some are owners, others are simply operators. We trained them in comprehensive family planning service delivery. And this included counseling, health education, referrals, administering short-term methods, then commodity stock management to ensure that there are no stockouts, and then data entry, management, reporting, and then linkages or working with the government to ensure sustainability. We also supported them to get accredited to receive free commodities for family planning. So in Uganda, we have two main mechanisms where a facility can receive commodities. One is public. So the National Medical Stores provides commodities or supplies the public facilities. Now, here we were dealing with the private sector. And what we did is got the other mechanism, which we call the alternative distribution system, to assess them and accredit them to receive services. The other thing we did was to carry out mentorship and supportive supervision, working closely with the government. And this was a sustainability measure where we work with the health, the district level health team, to support, to integrate these drug shops into their routine supportive supervision activities and support them to improve from where they are to a better quality service. We also worked with district mentors who are also mostly public health workers to pass on clinical skills and then other skills in data management and stock management. And then we also did what we call data quality assessment to make sure, again, that data is prioritized. Sorry? So this slide shows the results coming out of our work with the drug shop. So between January 2021 and September 2022, we saw over 5,000 people taking up services through these drug shops. And as you can see, over the quarters, this number went on rising. Now, if we go into the over 5,000 users, 29% of them were new users, so they had not used family planning before, while 71% were repeat users. Again, the drug shops were well distributed across the districts that we were engaging in this activity. And then of the total users, 22% actually got postpartum family planning. Of these, 12% got it within less than 3 weeks of the postpartum period. Again, among the users, 12% were adolescent girls 15 to 19 years. This slide simply shows us the method mix. The majority, 70%, took on injectables, so both the subcute and IM-DMPA. And then we have pills, the oral pills coming next, and then the condoms. Some of the lessons we learned while doing this work: working with the private sector, and in this case with the drug shops, reduces the burden on the public facility. It increases access to services, and so it lowers the unmet need for family planning. Training, we thought that training using a mentorship approach and then supportive supervision was so important in building capacity of these health workers. It is a sustainability measure because even when the project ends, these skills are retained by the health worker and they can use them. So that was something that we thought was really good. There was willingness to pay. We haven't really done a willingness to, a systematic willingness to pay survey. But from engaging and, with the users of this service, they are willing to pay for service as long as it is a quality service. And then we also found that anecdotal evidence from our work really showed that there's a need to scale up this service to other areas because it is greatly needed. So that is our work. And before I sit, allow me to introduce one person, Christopher. So this gentleman was at the center of this work in Uganda, and I thought he deserves recognition. Thank you very much.
Thank you, Rita. Emeka?
Yeah, good afternoon, everyone. I'm here to present on how we worked with the drug shops. In Nigeria, we call the drug shops are called the patent and proprietary medicine vendors. So I'm going to present on how we work with them to improve access to family planning services through a model that is designed by the Pharmacy Council of Nigeria. The Pharmacy Council of Nigeria is the regulator of the practice of community pharmacies and the drug shops. So this is a case study for 2 states, Lagos and Kaduna states. Next slide. Next slide, please. Okay, so I will take you through some rationale why we are working with the drug shops in Nigeria. And then, of course, a little description about what the tiered accreditation model is. And then our experience on the Integrate E project, the approach we adopted, some of our methodology, the key results, and then some of the lessons that we have learned. Next slide. Next slide, please. Just to set the context, Nigeria has a population of about 200 million. And in the focal states that we are working with, Lagos and Kaduna State, Lagos has an average population about 14.8 million, while Kaduna has a population of about 8.9 million. And almost a third of this population are women of reproductive ages. And in these two states, we could find that knowledge of modern contraception is very high. In fact, Lagos, almost about 99.9, while Kaduna is about 93.7. While the uptake of FP services is quite low, 29% in Lagos and about 12.9% in Kaduna. So you could see from this data that the problem is actually not the knowledge about FP services, it's actually the uptake. The knowledge is not translating to uptake. Now, PPNVs, like I said, I mean, in some countries they call them drug shops, but in Nigeria we call them the PPNVs. The PPNVs are estimated to be about 200,000 in number. And in Nigeria, they are always the first source of services, call it family planning services, other hygiene services, treatment of children under 5 and all that, because they are closest to the communities. And some studies also show that they account for about 72% of outlets that are stocking contraceptive services in Nigeria. That's quite huge. And it's also been found that these PPNVs are not a homogeneous group. A significant proportion of those who are practicing as PPNVs have one health qualification or the other. Next slide. It's against this backdrop that the Pharmacy Council of Nigeria, the regulators of the practice of PPNVs, decided to stratify them. In other words, to have them divided into tiers in accordance to the health qualifications that they have. The first tier looks at those that only have ability to read and write. And then, of course, they also assigned a limited scope of services for this tier. Then the second one are those who are either nurses, community health officers, or community extension workers who had either worked in public health facility before becoming a PPNV. So, of course, they also were allowed an expanded scope of family planning and other PHC services. And then the last tier now, which is the tier 3, are for the pharmacy technicians. Next slide. So I'll quickly run through our key lessons and what we learned using this model, because this was actually the model we adopted in the project. The Integrate E project is co-funded by Bill and Melinda Gates Foundation and MSD for Mothers. Our targets are women living in underserved areas of Lagos and Kaduna states. And then the duration of the first phase of the project started in 2017 and ran up to 2021. Next slide. Now, this is the work stream approach that we adopted because of the expansive scope of the project. We first of all looked at creating an enabling environment for the project, which is actually very key because this is the first time working with this cadre of providers to expand family planning services. So the first thing we did was to support the Pharmacists Council to design and pilot the 3-tiered accreditation system using the project. And again, to also strengthen the capacity of PCN to provide and to supervise community pharmacists and PPNVs. And more importantly, support policies that will make sure that it doesn't just stop at the project, but beyond the life of the project, these services can continue. And then the second work stream, which is also very important, is where we build the capacity of the community pharmacists and the PPNV for an expanded scope of family planning services. And this was actually done through the schools of health technology, because we realized that if we had done this through the project, you know, it ends when the project ends. So we thought right from the get-go, the need to institutionalize this through the schools of health technology. And then, of course, we supported PCN in developing a supervisory system just to make sure that there's a close supervision of the PPNVs. And then finally, we also created linkages to make sure that as they are providing services that are within their scope, those ones that are outside of their scope, they refer. And of course, a critical component of it is also the research to be able to generate enough evidence needed for the policy change. Next slide. Now, this is what we did first. We tried to understand the landscape, so that we'll be able to characterize the PPMVs appropriately. And what is you find at your left there is the GIS mapping conducted for the PPMVs. And what you will see, the pharmacies are at the center of the cities, while the PPMVs are at the rural areas. And then when you also go to Kaduna State, the same thing plays out. Where you see the concentration of the red spots there, the pharmacies, are at the major city centers. And then by the time you begin to fan out to the rural areas, you find more of the PPMVs. So again, this supports the need to engage the PPMVs for scaling up basic healthcare services. So you can see this is the total universe of the data for the PPMVs and the drug shops in Lagos and Kaduna State. Next slide. Now, these are the methodology we adopted. For the tier 1 PPMV, those that have only the ability to read and write, we provided 3 days FP training focusing on balanced counseling, oral pills, and the barrier methods. Then they also trained to refer for injectable contraceptives and implants, and of course IUD. Then of course value clarification, just to make sure that provider bias is reduced. And then they were also referred and linked to PAC services. So each of the PPMVs is mapped around a PAC services for referral. And then finally, we also supported them through the project-led supportive supervision and an integrated supportive supervision that is led by the state. And like I said too, at the design of the project, we are very conscious about sustainability. So we also made sure that the state is involved in supervising the PPMVs. Next slide. Then for the tier 2 and tier 3, who we all grouped together and called the health trained PPMV, they were allowed to provide implant insertion and injectable contraceptives. So their training was more expansive. So they were trained on oral pills, barrier methods, injectable contraceptives, implant insertions, and of course, value clarification. And then because they are supposed to provide invasive method, we also took them through 3 weeks post-training competency certification, just to make sure that they are competent before they start providing the services. And then, of course, we also made sure that we supported them through the process, through the project, and also through the state. Next slide. Now, this is some of the key results. You could see over 800,000 condoms were distributed, and about 140,000 oral pills were also distributed through these trained providers, and about 43,874 injectables, cutting across DMPSC, DMPA-IM, and then Noristerat. And then, of course, about 9,628 implants were inserted. This is very instructive because the injectables and the implants were not part of the bouquet of services that these providers were providing prior to the project. And in terms of the impact, almost close to 300,000 women have accessed family planning services through these trained providers. And then a third of that are those who accessed it for the first time. In other words, if these PPMVs were not trained, chances are that these women may not have had an opportunity to access family planning services. And then in terms of couples of year protection, we have about 62,051 and 17,871 unintended pregnancies averted. Next slide. Now, what is the lessons that we have learned and the key implications? We have actually shown from the results from the projects that the PPMVs, through the tiered accreditation, can be trained on an expanded scope of family planning services if properly supervised and supported. And then revising the tax shifting and the tax sharing policy actually sets the template to dramatically improve access through these providers. And I need to say here that this has been done. The 2022 edition of the tax shifting and tax sharing policy in Nigeria now includes the PPMVs to provide injectable contraceptives and implant insertion. And now the health-trained PPMVs, that's the tier 2 and the tier 3, present an opportunity for the country to rapidly scale up the DMPSC in line with the country accelerated plan. And then finally, we've also seen that without motivation, the PPMVs have ability to provide data, and this data can be integrated into the national system. This is one key learning that is important to us, because for prior projects, you have to incentivize the PPMVs to be able to report. But now they are beginning to own their data. Now beginning to understand what they can do with their data, even in their stocking practices. So we are seeing them reporting data consistently. Thank you very much.
Great, thank you. So if I could ask all our presenters to come take a seat up at the panel. And if we have questions from the audience, we can take a few questions maybe, and then we'll have the group respond. So are there any questions? Okay. So I said one over here, and then we'll...
Thank you very much for the insightful presentations. I'm Esther Muketo from Kenya. I'm working with USAID. So my question is around for both the presenters, supply chain. What are some of the supply chain challenges that you experienced when supplying to the private sector? And was it integrated into the national supply chain, or private also, maybe companies were given subsidies for that? And then the other question is around the challenges. In all the presentations, we've not had maybe any challenges that you faced in the process, and maybe it would be good to understand what are some of the challenges that you experienced in the process. And then when it comes to reporting, is it that you indicated that they were reporting to the DHIS for the ministry? Was it a separate system that was set up, or they were just integrated and accredited like the rest of the public facilities? Thank you.
So that seemed to be like 3 questions in one, so maybe we'll have them respond, and then we'll go to some other questions. I actually had the same question about the data, so maybe Dr. Emeka, and then we can move this way to respond.
Okay, thank you very much, Esther, for that very wonderful questions. I'll start with the supply chain. Yes, absolutely. We had some supply chain issues because, of course, in Nigeria, the private sector has a separate supply chain system from government. And because the private sector is profit-driven, and they don't receive stock for free from government. So oftentimes, especially around commodities like DMPSC, there was actually a period when we had a long stock out, because currently DMPSC is still from one channel, that's the Pfizer. So, and shortly after COVID, there was quite a lot of queue getting supplies from the manufacturer. So what we did at that point was to work with the Federal Ministry of Health to get what we call some loan of stock, just to make sure that we fill up the pipeline, pending when the social marketing organization in Nigeria that works with the private sector will receive stock, and then we can return. So that's actually how we dealt with, those supply challenges. And then, there were challenges we experienced at the outset. For a transformative project like this, there are bound to be issues. The associations came after us. The community pharmacists were wondering why we are training PPMVs and not training community pharmacists. Why are we empowering PPMVs? And of course, by the time we dialogued with them, by the time we showed them the numbers, in Nigeria as we speak, there are a total of 20,000 pharmacies that are registered from the inception of pharmacy practice in 1934 till date. And out of that figure, about half of that figure are those practicing in Nigeria. So there's no way that number can provide services to everybody. So it's actually when they saw this that they became, a bit, they started loosening up and saw the need to be able to train the PPMVs for an expanded scope. So I would say there is an ongoing conversation. The project has a steering committee made up of the PPMV leadership, community pharmacist leadership, pharmacy leadership, just to make sure that issues like this are nipped at the bud. And then, of course, finally, reporting system. Yes, in Nigeria today, there are two, what I would call national systems, the national HMIS and the community HMIS. The community HMIS was recently designed by government to be able to get data that are coming from the community. And within the community, we have practitioners there. We have some community volunteers that we call the chief's agents in Nigeria. We also have the PPMVs, we have the community pharmacists. So each of them reports their data now through the community HMIS. And with this data, there's visibility at the national system. So at some point at the national instance, there will be an integration of the community HMIS and the national HMIS. Thank you.
So maybe on this side, Dr. Koba, est-ce que vous pouvez discuter un peu des défis avec votre projet? Est-ce qu'il y avait quelques...
Could you please talk about the challenges of your project? Regarding the challenges, I would say that when you start working with the informal sector, you have everybody. You have the pharmacists, you have the doctors, you have the nurses. So, and also a lot of people who have no training but are still working in the pharmacy and are selling products. So the main challenge or the main obstacles we encountered were related to the profile of the service providers, especially in the pharmacies. Thank you.
Actually, sorry.
There's also a microphone in front of you, Monjin, on the table.
Yeah. Thank you. We work. Actually, I tried to present that private sector, definitely they have their own policy mechanism and system, but when we work collaboratively, then it must be handed over by the government, because otherwise the advocacy initiative or any initiative will not sustain. And therefore the MIS system is more important if the data is incorporated in the MIS national government MIS system, that it gives a satisfaction to the government as well as the recognition that the local level people are working and the CPR and everything is registered by the government MIS system. So actually it is the evidence how local level is working and the outcome is going to government data. So in a way we can involve private sector. It is not a single shot work. It's not keep private and public separately. Mix them. Use the data combinedly, and also, in our cases in Bangladesh, the service is providing by the government official by doing a camp. So in a way we can, even we are working with private medical college hospital so that their data also go to the national MS system. So government can see how the private medical colleges are working and helping to achieve the target of the government. That is an important thing, the collaboration and the data management system. Thank you. Thank you.
Rita?
Thank you. Thank you. So two things. One, on supply chain challenges, yes, the biggest challenge was stockouts. And this is really related to lack of visibility of service level data. And so it's not able to inform the needs for that particular facility. And this we addressed through capacity building of the drug shop operators in management of data and making sure that that data tells us what we need to know. Then on whether the supply chain system was integrated into the public one. So in Uganda, we have two systems that speak to each other. So the public one is the National Medical Stores, which serves the public facilities, while the private sector benefits from the alternative distribution system. So all the drug shops that we worked with, we made sure they were accredited to receive commodities through the alternative distribution system. Now, on reporting, the question was it integrated in the national system? Yes. So pharmacies and drug shops report through the National Health Information System, which is DHIS2, and they do this through the HMIS. And then how do they do it? So in Uganda, we don't have all the small facilities having an account. So what we do is they are attached to a public health facility in their catchment area. And so their data is reported through that public facility which has an account. Thank you.
Thank you for sharing your great experience in private sector. My question is related to user fee. So were there any efforts made to standardize user fee for different cadres? Consultation fee, I mean. So maybe the team from Bangladesh?
Yeah, I can. Can you just repeat your question?
So there were different private providers who were providing this service. So private providers have their own system of consultation fee. So were there any efforts made to standardize that?
Yeah. We are really struggling on it. When we're working to involve the private medical college, and then the Bangladesh government has the system of disburse, we call it impressed fund. So because all commodities and service charges free. So we had a long discussion with private medical college in Bangladesh, and we came up a decision that for commodity insertion, they will not take any fees. Government will disburse the money to their bank account. But it's not easy because the private medical college is self-sufficient, they are a lot of resourceful. So they are telling, oh my God, it's about 1 lakh, 2 lakh taka and a lot of hassle. So we can do this, we can do in our way, and for counseling we can get charged. So maybe for counseling, they are charging 200 taka or 500 taka, but when the government send the commodities like IUD, pill and everything, they are not charging. But some of the medical colleges, they decided, actually our focus on to include family planning service by the private medical college. So some of the medical colleges said, actually SMC is giving us in less price, so we will provide it to our way and give our data to government system. So we agreed on this. But most of the medical college has decided that is under policy process, that the commodity government will supply and we will record and we will provide to the MIS data. But for counseling, we'll take money, but for the commodities, we will not take money. So in a way, we are trying to adjust.
Thank you.
Thank you to all the presenters again. My name is Manish Berman, and I'm from Clinton Health Access Initiative. I had a couple of questions which have been asked before about challenges of working with the private sector. But my question right now, it pertains to sustainability. I know most of you spoke about how sustainability was baked into the program design, I was wondering if you had evidence of how sustainability actually played out after the program exited, and is it still sustainable given the complex nature of how private sector is and lack of / limited regulation that there is from the public, from the government in the private sector. I was wondering if you have evidence that you could share on how well this was sustained post your program. Thank you.
Yeah,
Yeah. that's it.
I'm responding in a very brief. Can I go?
Yeah.
Okay. It's just quick. I also shared in my presentation that we started with 10 fishing companies, then 22, and now the work is not in our hand. The divisional director has issued a order that it is the criteria of a companies, so that they had mandatory to establish a family planning corner in their premises, and they had collaborated with the local district family planning office. So monthly once the family welfare visitor, they have some mobile plan. It's a government plan. So they will go in each company twice a month. So it's not now in Maristop's activity. It is in government plan, government data. It's between now fishing department and the family planning department. We work like we mediated the whole work. So definitely it is sustaining. And that's the point we did it. It's the record, official order, and also their registered book. And we also involved the national government, national level family planning officials to monitor their commitment and activities. Thank you.
I'll add something.
Yeah, just to say, in the Integrate E project, like I mentioned before, sustainability was part of the design of the project. And as such, we embedded the training through the schools of health technology that are owned, some owned by government, some owned by the private sector. But they are there, they are providing training for other areas. They are training the community health extension workers, they are training the community health officers, and now they are also training the pharmacy technicians. So with this now, this has been included into their training curriculum. Now, for some states, particularly one of the states, Kano State, the project intends to train about 900 out of 6,000 PPMVs that were mapped in the states. We also, Kano was in our second phase. So, but we invited Kano to a neighboring state, Kaduna, where the project is being implemented. So the Kano official had a study tour to study what was done in Kaduna. And we are so impressed that the state government is now considering training almost an additional 1,000, excluding those that the project is currently working with. So that shows sustainability. And they intend to take this to all the remaining PPMVs in the states.
Okay, I'll add something on sustainability. So regarding evidence, I don't have that since the project hasn't ended, but we have inbuilt mechanisms to ensure that this work is sustainable beyond the life of the project. One, we are working with a district health system, which is within the national health system. So these drug shops have been included on the routine supportive supervision schedule for the district health leadership to ensure that they maintain quality throughout. Number two, capacity building of the health workers, the drug shop operators. This knowledge and skills will stay with them. And it's not just clinical skills, but also data management, supply chain, and stock management. That is also a sustainability measure. Lastly, the source of commodities is through the national system, and that runs. So even when the project comes to an end, they are already accredited and they continue to receive commodities through the national system. This means that the commodities will be available, the health workers are trained, the work should be able to go on. Thank you.
Thank you.
Je voudrais tout d'abord féliciter les différents présentateurs pour la
Want to congratulate the speakers for the quality of their presentation. I am very interested by this strategy through pharmacies because in Senegal we carried out a study with women in the productive years to make sure they get training, and 90% of women had connections with the pharmacies because it's a really close service that can be provided there. And we were able to gather data about the health of those women. So we could use pharmacies as a strategy to improve the use of family planning by women. I have one question. In our country, in Senegal, the offer of services of family planning is not allowed. How is it in your countries? To give an implant is not authorized in our country. You can take pills and things like that, but you can't insert the implant. It's not authorized. So I was wondering whether it was the same in your countries. Do you have the same problems? I hope you understood me.
deliver implants. So how about in your country? If we are in the same situation, how did you implant this project without the situation about the law? Sorry for my English.
Okay. Yeah, we had the same challenge in Nigeria. The law does not allow pharmacies and drug shops to provide injectable and implants. So the first thing we did was, because I said it started as a proof of concept. So we discussed with the government to say, look, we are going to pilot this with a fraction of the population of community pharmacies and PPMVs. We'll give you periodic reports as we progress, evidence of what works and what doesn't work. So we had to apply for a waiver, and then it was through that waiver that we jump-started the project. And then, of course, government is now beginning to see that if these people are trained and properly supervised, that they have the capacity to provide it. So, and that's also the reason why the new tax shifting and tax sharing policy, like I mentioned now, has included them. And that's a policy document of government.
Yeah. Oui, par exemple, pour le cas de la RDC, donc.
In Congo, the supply of services by pharmacies is not authorized. So we are advocating this. This study was implemented so that we could gather data to show that it was feasible and acceptable, and that we could use those pharmacies as a supply site in support of the users. Because as you know, with subcutaneous injections, there are various profiles. Some women can do self-injections, others need the help of the health carers. So for this study, we targeted the first category of women, the women who are able to do self-injections. So this is the situation.
I had the opportunity to hear two of you. So my question is related to the incentive. What was the incentive of pharma providers to get into that network initiative? What drives them? They are making money without you, right? And so what drove them? And not only for few who are more altruistic driven, but for the masses, larger number. And what will drive if you go from 1,000 to 15,000 or 50,000? I saw somebody ask 3 questions, so maybe I'll take 2 only. My second question is on talking on the accreditation models. You talked about tier 1, tier 2, tier 3, and some kind of a tiered accreditation model. If you can briefly elaborate on it, because accreditation gets into some legalities as well. So, yeah, I'm Somesh from Japaigo. Sorry.
Okay, thank you very much. I'll start with the first question around the incentives. We just concluded a recent study, not by the project, but by another organization working with the PPMVs that had been trained on the 3-tier accreditation. And one instructive insight was that a lot of the PPMV, over 97% of the PPMVs that were accredited, now have been able to make more money as a result of the expanded FP services that they now provide. So they now have more confidence, with their clients. So the client inflow had increased significantly. So now a lot of them that were not part of this network are even ready to pay the cost of training involved in the accreditation system. So we have seen that happen, and that's actually how this will be transitioned at the end of the project. So the PPMVs themselves will be able to pay for the accreditation process. And to also answer your second question, again, I won't be able to explain the entire process within just 15 minutes. But the accreditation process is not just the training. The training is a component of the accreditation. There's also accreditation of the premises to make sure that it meets the standard for the different categories of the PPMV. The Pharmacists Council of Nigeria has, for each PPMV, each tier of PPMV, there's a separate standard that they all have to meet before they get the full accreditation. And then, of course, there are also the issue around branding. There's also a brand that separates one tier from the other, so that if you're going to tier 1, you know what services to expect. You're going to tier 2, you're also going to tier 3. And from time to time, the Pharmacists Council will reevaluate those PPMVs to be sure that they can still be continually accredited. So this is just an entry into the accreditation process.
Any other questions for our panel?
Yeah, thank you very much. 2 questions. I wanted to check on the cadre of the health workers who work in the PPMVs. And then 2, how are you able to differentiate between make sure that there's no leakage between the social marketing product and the government product, because we know we do not have social marketed products from Pfizer allowing to repackage. How are you dealing with that? Thank you.
Excellent questions. The first one, the first tier of the PPMVs are those whose only qualification is school certificates and maybe bachelor's degree in non-health areas. So PCN has said that, look, these people are in that business principally just to make profits. So there's a limited scope of services that they can render. So, and that's what they are being trained to render. Then those that have health qualifications, either nurses, community health extension workers, community health officers, who had in the course of their career maybe exposed to some practice in the public sector and retired to set up a PPMV, they belong to another category called the tier 2 PPMV. Then of course the last tier now are for the pharmacy technicians, who are also being regulated by the Pharmacists Council. Then the issue of leakage, yes, we keep having that, especially when there is commodity stock out. You see some commodities leaking from the public sector to the private sector. But the private sector stock is completely demarcated. They are always individualized in terms of the packs, while the public sector stock are in hospital pack, in bulk packs. So that's the first distinguishing factor. But again, too, we work very closely with the state government to make sure that, the PPM, because the PPMVs are there for profit, they sell the commodities. The commodities are not free. So we work with them to make sure that these commodities don't get to the PPMV, because oftentimes that's where the source is, the public sector.
Any last questions for panelists? All right, well, thank you very much. And this was very insightful and very interesting, and I appreciate it. Thank you.